session with Dr. Dennis Lai. So before we start, I would call on Dr. Dennis Lai, who is a public health consultant and the Deputy Director Surveillance for the Ghana Health Service, to introduce us to this important sensitization exercise. So Dr. Lai, I don't know if you can hear me. If you can hear me, over to you.
Yeah, thank you very much, Dr. Taub, and good afternoon to you all. Right, I think Dr. Taub has highlighted that people could be in other locations. So good morning and afternoon and evening, wherever you find yourself, and the appropriate salutation. I'm certain that we all know that Mpox is currently an issue that Ghana as a country is having to deal with. It's been going on in some countries. But somewhere last month, we recorded our second case for the year. And subsequently, we've recorded quite a number of cases. And the indication we're having is that the cases are on the ascendancy. So we need to, as it were, have this session. And we know several other sessions on Mpox have also been organized by other stakeholders, all in the spirit of ensuring that we are able to contain the outbreak and see to its conclusion to allow us to go back to our normal lives. So this CPD is targeting all healthcare workers. We're not targeting any specific group. The presentations are aimed at getting us all to see where we fit into the scheme of things as far as our actions or response to the outbreak is concerned. And to be able to do this, we've looked at the 4 broad thematic areas in our National Public Health Emergency Operations setup. And so surveillance, the lab, case management, and risk communication, those are the 4 pillars. And we have seasoned personnel from within the Ghana Health Service who will be leading the discussion as far as this is concerned. The last time we had a CPD on Mpox, we saw a steep rise in the number of suspected cases. It didn't necessarily result or in a correspondingly steep rise in confirmed cases. But what that tells us is that there was heightened surveillance, heightened sensitivity of all of us in suspecting cases and taking samples. We know that typically for chickenpox, we would not undertake any clinical investigation if that is our suspicion. We'll just manage it, as it were. And given that there are some similarities as some face or even atypical presentation for this disease, it's important that we refresh our minds on this. And so we will have presentations focusing on the 4 thematic areas, as I said, I mentioned earlier on. The first, we'll look at our current situation. We'll get updates on our numbers. And then the issues around surveillance, including contact tracing and management. And then we'll look at the clinical side of things, including the management of cases, what to do, what not to do, and when to seek further care. And then we'll have a look at the critical element of sample collection. So the appropriate samples to take, how to package them, transport them in the designated lab for testing. And then we'll finally also look at the issues around risk communication. And that starts from our OPDs, through our consulting rooms, all the way to our communities as well. What kind of information we should provide and how this information should be communicated to ensure that we have the public on our side, because without them, we cannot deal with this outbreak. So with these comments and the discussion of the objectives as to why we're having this CPD, I will hand back over to you, Dr. Taub, to do the moderation for now, and I'll chip in as and when. Thank you very much once again for joining. Over.
Thank you very much, Dr. Lai, for that brief introduction of today's CPD and what we have ahead for ourselves. A few ground rules before we start. So if you have any questions, we will take questions at the end, but as and when the presentations are going and you have any question that you want to ask, you can use the Q&A for that, and the facilitators would be there to try and respond. Those that need to be responded at the end, we'll do it at the end. So we'll start with our first presentation, which looks at the current Mpox situation in Ghana, issues relating to surveillance, contact tracing, and how we even manage our contacts. I would call on Dr. Med Joshuata, who is a public health physician specialist and the current acting public health emergency operations center manager. So Dr. Joshuata, over to you.
Thank you, Dr. Tawa. I guess I can be heard now.
Yes, Dr. Tata, you can be heard, but I think if you amplify your voice a little,
Okay, so I hope this is better now.
Yes, this is better from
right. Right. So thank you for the introduction. I am going to take us through Mpox surveillance, and when we say the role of the clinician, we are actually talking about the role of all healthcare workers, with detection being the key for surveillance. So a bit more for the clinicians. As an overview, Mpox is considered a zoonosis, and it's caused by the monkeypox virus. Once a person has the virus either from an infected animal or other infected humans or a contaminated material or surface, then infections can occur. Other ways like a bite or scratch from a primate or a rodent can also transmit the virus. And again, human-to-human transmission occurs through close contact with the lesions. So all forms of physical contact with body fluids, and then later on we'll look at the role of infectious respiratory particles, so respiratory droplets, either directly or indirectly. An incubation period is normally maybe just about 3 days to about 2 weeks, and you can have it anywhere from 2 days after exposure to about 21 days after exposure. All this period, there may be no symptoms. And so that is something that is important. It becomes very important when we think of contact tracing that we'll discuss later in this presentation. Mpox is similar to but milder compared to smallpox. Smallpox is now considered eradicated. Mpox is quite common in our part of the world, especially in the West and central parts of Africa. And as we will see when we talk about the previous outbreaks, it is now quite common around the world because of what happened, especially from 2022. We can talk about Mpox in two clades, clade 1 and clade 2. And if we were going into details about this, then we'll see that it also has some impact on how various outbreaks have played out. Mpox typically is self-limiting. However, there can be mortalities, and mortalities up to about 10% have been recorded, particularly amongst children and other vulnerable groups have been recorded. When we want to talk about Mpox taking the headlines, even though Mpox had been considered endemic, especially in West and Central Africa, there was a global outbreak in the year 2022, and it's led to declaring Mpox as a public health emergency of international concern, meaning that Mpox came to the world's attention and we put ourselves on the highest alert to draw in all the resources necessary for its control so that we could get out of that outbreak. Now, as Mpox looked at going down in 2023, there was an upsurge of cases in the Democratic Republic of Congo, led to the detection of a new subclade 1B, and then this also spread to neighboring and other countries. So the PHEIC that was declared back in 2022 was extended. And so as at now, the world is still under a PHEIC for Mpox until August 2025. And a lot of recommendations have attended this extension with lessons learned from these outbreaks. Coming to Ghana, we also recorded cases in that 2022-2023 outbreak. However, after about October 2023, we had no cases until September 2024. We had about 5 cases in all. It is notable to say that all regions, the whole year round, kept on suspecting Mpox cases. And this is important because it speaks to the fact that the surveillance system for Mpox was active in all those periods. In this year, 2025, there was an isolated confirmed case of Mpox in February 2025. In that period, no other case was detected. However, in May 2025, a series of confirmed cases were detected. And so we have now noted an upsurge both in the number of suspected and confirmed cases since this May 2025. So to give a snapshot of what has happened so far, we have about 347 suspected cases as at the 31st of May, out of which 45 are confirmed. Again, all 16 regions are reporting suspected cases, but confirmed cases have been reported from 9 out of these for all 16 regions. Currently, majority of cases are on home isolation, and there have been no deaths amongst the confirmed cases. This is an epic curve showing the cases by date of onset, and you can see from the week 17, there have been consistently every week reports of confirmed cases, and then an upsurge in the number of suspected cases reported across the country in the past 3 to 4 weeks. So this gives us an idea of what our current situation in terms of the current outbreak looks like. To continue on Mpox surveillance, Mpox is part of the diseases under surveillance in the country. We use the term notifiable disease or priority disease to refer to this. So if you were to take the guidelines that's direct how we approach public health surveillance in the country, you would see that Mpox is actually listed in there. The surveillance goal for Mpox, and I want us to know it very well, is to detect and immediately respond to any suspected case of Mpox. So our main is that we would pick up any suspected case of Mpox and immediately move into action. And some of these actions we would note as we go on, as far as surveillance is concerned. So our approaches to Mpox surveillance fall into 2 main categories: our indicator-based surveillance using our case definitions, and event-based surveillance, where sometimes people may just report unusually that a number of people are coming showing around us with rashes or being sick, and they may not even specifically make reference to Mpox per se, but once it's something unusual, our investigation may uncover that these cases actually fit a case definition for Mpox. Again, our surveillance includes actively going to look for this information or receiving reports from either our clinicians, other healthcare workers, or members of the community, even through media reports and the like. So for Mpox case definition, especially under the indicator-based surveillance, we are looking at the suspected case definition being an acute illness with fever greater than 38 degrees, intense headache, lymphadenopathy, back pain, myalgia, followed by 1 to 3 days later, progressively developing rash that often begins on the face and spreads to other parts of the body and can affect the soles of the feet and palms of the hand. So it's important to note that a lot of Mpox cases may first come to us with prodromal symptoms, just fever, maybe just headache, bodily pain, weakness, and we may also note lymphadenopathy on examination, or they may report that they've noticed, a lump in their armpits, wherever, and then later on, they may come with the rash. This is important to think of when it comes to case identification, especially in our facilities. A probable case meets this clinical case definition, but we are also able to link it to another confirmed case or another probable case. And typically, we would not have had laboratory confirmation done yet. And for a confirmed case, it's a clinically compatible case that is also laboratory confirmed. So these are the 3 levels of case definitions that help us to identify, detect, and report on cases of Mpox in our facilities, in our communities. What do we do when we are suspecting an Mpox case? Once we suspect an Mpox case, remember that the main goal is to control, break transmission. And so it's important that that patient is isolated. And because of the possibility of respiratory droplet
Dr. Ta, you are muted.
Am I back on? I think
Yes, you
I
are
may
back
have.
on.
Right. So it's also
And
important
and
that
Dr. Ta,
also,
your slides are not showing. If you can reshare.
right.
And if you
Please
can
let
use
me
the
know.
full screen. I think we are seeing half screen.
You're seeing half screen? Okay. All right. Are we back on now?
Yes, your slides. Can you put them in slide mode?
Are we back on now?
Yes, we can see your slides
Great.
now. So full
Great,
screen,
great.
then
Thank you.
slide show.
So can you see the screen now?
Yes, Doctor, I think you can continue. Yes, we can see the screen. I think let's continue.
Thank you very much. Yeah. And it's important that all staff attending to the patient use appropriate PPEs. This is right from the time that you are suspecting the case. It is important to treat and manage the patient supportive care or symptom-specific management. Again, it's important to notify the case, and this would include reporting case-based information to the next level. This would typically have to be a collaboration between the clinician and the disease control officers, where the clinicians can provide appropriate case-based information, symptom information, and all that for disease control officers to document, see, and report to the next level. It's also important to collect and transfer the specimen to the lab for testing and possible confirmation of the case. It's important to also implement the necessary risk communication, community engagement, contact tracing, and contact management procedures. And all this is being done at the point that we have a suspected case. And then continue surveillance so that we will continue to pick up other potential cases if they come to our attention. If a case is confirmed, then it is important to ensure strict infection control measures throughout the duration of the patient being in the hospital. It's important to look at what structures have to be in place for early detection, containment, and the care of the confirmed cases in our care. And then look at community education, looking at transmission, implementing control, infection prevention control, especially if the cases have to go home or if the unfortunate happens and there's a need for even a funeral and all that. We also have to continue looking at community case search for additional cases, because what presents to us typically is the what we say the tip of the iceberg. And of course, the control of Mpox outbreak requires broad stakeholder consultation and collaboration at all levels. So in the facility, all stakeholders need to be acting together, same at the district, region, and even at the national level, where we have to bring in other partners to ensure a complete response and containment of the outbreak. When we look at health worker roles in Mpox surveillance, it starts with detection and notification. So our ability to identify and diagnose Mpox cases using the standard case definition is a role that healthcare workers, typically led by clinicians, and are very much involved in. The notification of these cases to the public health unit, either in the facility or the district, is also a role that we all have to play. Then comes public health investigation. So reporting this case, being able to put together complete case-based information that includes the history and other clinical details, we all have a role to play. The collection of the appropriate specimen, and I think the presentation on lab will shed more light on this. Typically, our interaction with the case means that we have a good idea of who potential contacts, especially staff and relatives, may be. And we also have a role to ensure that these are appropriately listed and they can be followed up as part of containing the outbreak. Sometimes, as healthcare workers in different capacities, we actually have to support outbreak investigation so that we can have the appropriate information and implement the control measures that are required. Beyond this case management and the isolation of suspected or even confirmed cases to prevent spread, it's a key role that all healthcare workers have to play at the facility, and sometimes even in supporting community isolation or home isolation of the cases. Relevant IPC measures. And we want to remember that these IPC measures protect ourselves and protect others. It is usually not the best that once a case is confirmed, we list so many contacts, and you find out that typically 70% or more of these contacts are healthcare workers. So it's important that we have a role to stop or break the chain of transmission by applying IPC measures that protect ourselves and others. And as healthcare workers, we also have the role to provide supportive care to either suspected cases in our care or confirmed cases in our care. And this includes ensuring that their psychosocial state and support is taken into consideration. I think that the presentation by Dr. Komi will touch a lot more on this. Similarly, we have a lot of power in terms of communication to provide health education to our patients and their relatives when it comes to the outlook for the disease, when it comes to the adoption of preventive measures and assuring them. So we may say that there are other people that have to do this, but if they hear from their own caregivers, from their doctors, from their PA, from their nurse, explaining some of these things, the message hits home and it's important. And it's why we have these components in today's presentation, so that we are better placed to do some of these education for our patients and relatives. We want to touch on contact tracing. So who is a contact? A contact is a person who has been exposed to a probable or confirmed Mpox case during the infectious period of the case. Remember that we said that someone can incubate for up to 21 days. Once the person begins to show symptoms, including prodromal symptoms, the person is considered infectious. So once someone came into contact with a confirmed case or a strongly probable case at the time that they were displaying symptoms, then that person should be considered as a contact. And then what is contact tracing? Contact tracing is a public health measure, and it's used to identify exposed individuals, monitor their health status, implement infection prevention measures, and also able to early detect their infection so that we can break the chain of transmission. So the key outcome for contact tracing is to quickly ensure that any potential secondary infections are picked up as quickly as possible at a time that they may have little or no risk of having infected other people. It's important to understand this, and that goes into the recommendations that we all want to implement when we are dealing with contacts of cases. So how can exposure happen? I think the presentation on case management also shed some more light on this. For now, we want to understand this in 3 ways, 4 major ways. Direct contact, which is skin to skin, skin to mucosal surface, or mouth to mucosal, physical contact. And this then also includes intimate, oral, or other sexual contacts. Indirect contact with patients' clothing or bedding, it's also another means of exposure. And non-physical contact, sometimes being in the presence of a symptomatic Mpox case, face-to-face, or any close proximity, that means that there's a high risk of coming into contact with the infectious respiratory particles. That increases the risk of actually contracting Mpox. And so such people are also considered contacts. Mother-to-child contact or vertical transmission also does occur through in Mpox. And so such instances, the child can also be considered a contact. Of note is that healthcare workers are typically exposed either through indirect or non-physical contact, and also with the absence of proper use of PPE. As you can see, the proper use of PPE is highlighted there. So a few times we may be adopting IPC measures, but we need to ensure that we are doing it well. And we also need to have at the back of our minds the application of universal precautions at times that we are dealing with potentially infectious patients. What measures do we want to put in place for our contacts to Mpox cases? There should be daily follow-up for up to 21 days, counting from the date of last contact with case. So if someone is confirmed today, and I have listed a contact who had the last contact 5 days ago, it means that 5 days of the period has already elapsed, and I'm continuing from 6 up to 21 days. During this period, the need for follow-up, and the follow-up includes monitoring general health status and immediately reporting any unusual symptoms, typically the prodromal symptoms, or if there is a rash. At the time that contacts are under follow-up, a key aspect of their education is the regular practice of hand hygiene and respiratory etiquette. Because if there is a risk for transmission and they begin to develop or become infectious, this is how they pass it on to others. It's also important to counsel and support contacts to avoid close physical contact, including sexual contact. Also to avoid close physical contact with persons who are immunocompromised, especially also with children. As a precaution, contacts should be discouraged from donating blood, sometimes even breastfeeding, looking at how we assess the risk. And this will be done in conjunction with a qualified pediatrician. Remember that transmission through semen have been documented. And so contacts should also be advised to avoid sex or contact with semen during the period of follow-up. And as much as possible, travel should be discouraged. These are sometimes difficult, but that is the role of very good risk communication and support to both up and their contacts. And if we're able to do this well, it helps with achieving some of these things. What do we do for symptomatic contacts? It may be that a contact under follow-up may develop fever, some chills, prodromal symptoms. For such contacts, physical examination should be done, specifically looking for rash all over the body. Even in the absence of rash, such contacts should be tested by PCR. If they are negative, they go back to completing the 21-day follow-up. If a contact develops rash during the period of follow-up, we should ensure immediate isolation and testing. Even if this contact is still negative, they should also complete the 21-day follow-up. It goes without saying that if at any point in these two scenarios, the test comes back positive, that contact is now a case. And so it's converted to a case and managed appropriately. Contacts are followed up for the 21 days, and if there are no symptoms, they are discharged. There is no need to test these asymptomatic contacts at the end of the 21-day period. So to sum up, talking about our surveillance for Mpox, we want to note that Mpox has been considered endemic in West and Central Africa for years. Back in 2022-2023, we recorded Mpox cases, and we continued routine surveillance to be able to detect suspected and confirmed cases. Currently, we are experiencing an outbreak of Mpox with a surge in confirmed cases in the month of May 2025. There is a need for clinical awareness amongst all healthcare workers to promptly detect, notify, and investigate all suspected cases of Mpox. And as healthcare workers, we have crucial role to ensure the prompt detection, management of suspected and confirmed cases of Mpox. On that note, thank you very much, and I'll be available to take any questions.
Thank you very much, Dr. Atta, for the presentation and the insightful summary. So I picked up a few points that all the 16 regions have reported suspected cases of Mpox, with 9 regions having confirmed cases. And for the incubation period, it's usually between 3 to 13 days, but it can range from 2 to 21 days. So when we are taking our detailed history, we should be mindful of these dates. Then for the surveillance goal is to immediately detect and respond to any case of Mpox. And that is why we need the clinicians to be on the alert to be able to immediately pick up cases so the various public health measures would take place. So we'll take the questions at the end. So we'll call our next presenter who will take us on appropriate sample collection, packaging, transport, and testing for Mpox. She's no other person than Dr. Gifty Boateng, the Deputy Director, Department of Public Health Laboratories of the Ghana Health Service. So, Dr. Boateng, over to you. Can you see the slides from my end?
Yes, please, Dr.
Okay, and Dr. Boateng, please, over to you.
Okay, thank you very much, and good evening, good morning, good afternoon, depending on your location. We've had a very good introduction from Dr. Arthur, and I'll continue with how to manage our samples. Next slide, please. So by the end of this session, we want to make sure that we can collect our samples appropriately following IPC. We should be able also to transport our samples and also make sure that our waste after our sample collection, we handle it properly. Next slide, please. So to start with, we always will say that for the lab, whatever results that we give out depends on our sample. And therefore, the quality of our samples and how we receive the samples on time would always affect our results. And therefore, when we are picking samples, we should have this in mind. If we want to get a good result, then we need to make sure that the first step of getting a good result is the quality of the samples and how early the lab receives the samples. Next slide. So the responsibility of sample management, as we always say, is the lab. And therefore, if you are handling samples, kindly contact our lab professionals who will guide you on what to collect, when to collect. And for this matter, we are talking about Mpox. So if you are in doubt, you contact our lab personnel who would let us know what sample to pick, when and how to do that. The appropriate containers to use, and also how to label our samples, and then how to make sure that at the pre-examination phase, we assess all these samples and get a good result for you. Dr. Tawa. So now we want to move on to how to collect our Mpox samples. What do we do? To collect a very good sample, we need to make sure that we are following these principles. We need to get the right sample. And when we say the right sample, we mean you have to collect the right type of sample. So for Mpox, what type of sample are we supposed to pick? We'll talk about that. The time of collection is very important. And also who is collecting it is also important. You can only do these things when you have a very good SOP. And so please, we need to have SOPs in place, and the lab, we have developed that. So if you don't have it, you contact our lab professionals, you have it. We need to make sure that we have completed our forms or we've entered them into our SOMAS, and there's no contamination, so that whatever result that we get, we'll know that it is coming from the patient and not you, the collector, or the environment. We also have to make sure that after collection, we are safe, the environment is safe, and our client is also safe. And we also make sure that we properly store these samples, and then we use correct equipment. When we put all these principles together, we are good to have a very good sample. Next slide. So who should be tested for Mpox? Dr. Atta has really laid the baseline for us. We need to meet the case definition. And so he really explained what a case is and what definitions we should use. And so you have to use the case definitions. And then whoever meets or whoever is a suspected case, we have to test you. And whoever is a probable case, we also have to test you. So in saying this, you realize that I did not talk about contacts. So if the contact is not, you are not suspecting the contact to be a case, please, you do not test that person. And if the person is also not probable, having been linked to a confirmed or a clear epidemiologically linked case, we do not test those people. So please, let's take note of that. Let's not test contacts who have no signs and symptoms. Next slide, please. So which samples do we collect? We go into details, but these timelines helps us to know at what time and what sample to pick. So like I said, if you have contacts who have not shown any signs, we do not take samples because they'll be in the incubation period. When you collect these samples, we are not likely to get any good results or any positive results for you. But we collect samples, and the right samples we will discuss into detail when you are between 2 to 4 weeks. And then when you are recovering, the kind of sample we collect is the serum. So please, those of us who are collecting blood as our first choice of sample, no. We collect that when you are not seeing any of the things I'm going to talk about, the lesions, the crust, then you are asked to collect serum. So serum should not be our first choice of sample if you have the lesions and then the crust of a case. Please, next slide. Before we collect our sample, we need to make sure that we have the right PPEs to use. And so our N95, our gloves, our gowns, face shield will be enough to collect an Mpox sample. We have to also make sure that we have our permanent markers to write, either we are using a case-based form or a data collection sheet. Those of us who are using barcodes, and therefore we enter into SORMAS and we use our data collection sheet to send the samples to the lab. The kind of swabs we want to use are the ones that has the polyester or nylon or dacron tips. We do not use ones that have the cotton tips, and we'll see that on the next. And please do not use any preservatives. We only would use the polyester, nylon, dacron, dry swabs with no preservatives, please. We do not want the next slide, please. We do not want the swabs with wooded shafts, the one you see on my right, with cotton tips. No, these ones are not good because the kind of test we are going to do for you is PCR, and these swabs are not good for us. We also make sure that as part of the things that the checklist that we would need is our sharp containers, our autoclave bags, because when we finish, we need to decontaminate our waste well by autoclaving them, having hand sanitizer, and then a viral transport medium. For blood samples, we will need our syringe needles, tourniquet, vacuum container needles, and then EDTA tubes. So these are the ones that we normally would use for our serum, and so the same things we will need for Mpox as well. Next slide, please. So now what are the recommended type of samples that we need? We need the swabs of lesions from surfaces or exudates, from crust, and crust is the most suitable one that we want. If none of these two are available, then you can take oral swab or whole blood, where we take the serum out of that. So please, the best sample for us is swabs from lesion surfaces or exudates, and then crust. The oral swab and the blood, you only take when you do not have any of the above, and therefore you add these ones to it. So please, the last two should not be the preferred choice of sample for us, but the first two is what we would really want. And please, when we take these samples, we should make sure that we've labeled them with a full name, age, and sex, the dates of sample collection, because it helps us, and then the specimen time. Sometimes when we do the case-based forms, or you do not enter into SORMAS, and we have these things written on the container, it helps us to know what to do and how to. And also, please make sure that you are adding the type of sample on the tube as well. Next slide. But before you collect, as I have said in the checklist, you need to wear the appropriate PPEs, which I listed above. You collect 2 swabs each from 2 lesions. So if you have different types of lesions, kindly make sure that you're touching about 2 or even sometimes more from different locations on the body. And then you put these 2 in the same container. We've had a case where we pick samples, people touch different lesions and put them in different tubes of the same patient. No. When you do that, we are confused to know whether, and sometimes we do not also label, so we don't know whether it is oral swab, whether it is the same swab from the same patient, and then we don't know how to pick them and test. So please, when you take the different types of swab from the patient, put them in the same tube and label appropriately. You are using the sterile swabs as I talked about, and please, you do not use the swabs with the thin aluminum shaft. Before you collect these samples, do not clean the lesions with ethanol or any other disinfection before you collect. Please do not do that when you are collecting the swabs from the lesions for the lab. The next slide, please. So you have seen the lesions. How do you do that? You have your swab with you, you have your VTM. You have to vigorously ensure that you have adequate sample collected. And so you hold firm enough on the swab, the shaft, and make sure that you press and you vigorously would swab on the lesions. You have to avoid swabs that will bend, as I said, so it should be firm. Your shaft should be firm. And then you have to make sure that you are collecting the sample. When you have exudates, ensure that your swab can pick enough that you can visibly see before you put into the swab. And then you wipe any excess, or you go back and forth, and then you put in your container, and then you package it appropriately and send to the lab. So we are saying that lesions and crusts and fluids should not be mixed together. So you are picking swabs of lesions. Please, if you have that one and you have the crust, don't mix them together. So for the same patient, you have the swab in a VTM or in a dry tube if you are coming to the lab as early as possible. And then you have your crust separately in a cryo tube. So do not put all these 2 together in the same container. Separate them for us and bring these 2 samples in the same transport or transportation box and bring it to the lab. So we accept both dry swabs and VTM. But for the dry swabs, you need to get to the lab early. So if you know you can't get to the lab early, then you use the VTM for us in the transportation. And where resources permitted, you can collect more than 1 or 2 of the samples, and then you send them to the lab. Next slide, please. So for the crust, we've talked about how to collect the swabs from the lesions. For the crust, you would have to use forceps or any other blunt tipped sterile instrument to remove pieces of the crust, at least about 4 millimeter in size, and then you put in a cryo tube, a dry tube, of course, and then you package it nicely and send. You separate each crust into dry sterile containers, I've said, and then when you have removed this crust, you cover the patient with the lesions with a plaster. Next slide. For oral pharyngeal, because of COVID, we are good in taking this. And so if you are not able to get the swabs from the lesions or crust, that is when we say that resort to oral pharyngeal swabs. And this is what we did during COVID time. So we are very good in taking this sample. So normally we take the swabs from the throat, and then we will do just as we did for COVID. So we can continue. For blood, as I said, it is also the last resort when you are not seeing any of the lesions or the crust, and then you take the blood. And so you are taking about 3 to 4 mils of blood into EDT. You separate and then you bring the serum. If it is the whole blood you are bringing, please do not put it on ice for it to hemolyze, and then you need to get it to the lab as early as possible. Next slide. So for blood, as I said, it is not used for diagnosis, but normally would use it when we have IgM kits available, and then we'll use that. So blood should not be your preferred sample. For now, we are testing with PCR. We are using PCR to test, and therefore swabs from lesions and crusts are the good standard for our diagnosis. We are emphasizing on this because the kind of samples we are getting are still blood, and therefore we are leaving the crust and the swabs. That is why we are stressing on that. So in summary, for the sample collection, we are saying that before you collect any sample, we need to fill our case-based form or enter this data in SORMAS. If you are using barcodes, you come with your submission sheet. Make sure that we've labeled our samples appropriately. We are getting a lot of samples that sometimes comes without any label, and therefore you don't know what to do. Some also comes with the form alone, and then the samples are not accompanied. These are things we are seeing. You perform your hand hygiene, and then you collect the appropriate samples that I've talked about, and then you package it nicely. We'll talk about the packaging in our subsequent slides. And then when you are done, you would have to doff off your PPEs, and then you do perform hand hygiene again. Next slide. So now you've collected your sample. Please label it very well. And then make sure that you are cross-checking the information on the tubes and the case-based forms. As I said earlier on, we are having a lot of mismatch. Sometimes the names on the tubes are not the same as also in SORMAS. And some of us are also not using barcodes. And therefore, when we scan, we are not able to scan. And so that if what you have even on the tube is different, but the barcode is there to give to guide us to get the correct matching for you. So please, anytime that we label our samples, we need to cross-check with our case-based form so that we don't send samples to the lab, waste all the time, and therefore we are not able to test for you. Next slide, please. And so we are saying that if you do not label well, just something that we will call it common by labeling is not common. When we don't label well, sometimes we delay in reporting. There are some of our health workers that we call to inform you that we don't have the appropriate matching of your sample, so bring another one. All these things result in delay. Sometimes also we would have to withdraw the test and we are not able to give a result on time. When we don't label well, our patients are not satisfied because we are delaying in getting results. We get a lot of calls where patients want results, and therefore, Mpox, most of them are not really very sick and lying on bed. So when we delay in results, they agitate and they want to go home. We also, when we don't label very well, we would increase incorrect diagnosis and also treatment. Next slide. And sometimes it can even result in death. Next slide, please. So now we have our samples. How do we package it and send it to the lab? When we collect the samples, we need to send the samples immediately. We need to send the samples immediately. We shouldn't batch them in sending. When we get the samples, we need to send them immediately. And therefore, when we are sending, at what temperature should we send the samples? The right temperature to send these samples should be 2 to 8. If you know that you are not getting these samples sent to us immediately, although we would want it to be sent immediately, if it is within 7 days, please store it at -20. I know for those who do not have labs and then would have to store the samples, normally the common temperature that we have is the -20, but if you are within a lab, you can have the -70 and then you can store that. We are recommending that you do not freeze and thaw. So do not remove the samples, you freeze it, you thaw, you take it back. So if you are not ready to transport, please make sure you are ready before you bring the samples out, because the freeze and thaw affects the quality of results that we get for you. Next slide, please. So for packaging, we are using our triple packaging. Most often the packaging we get is just double packaging. The secondary package, we always miss them. So when we talk about the primary triple packaging, we are saying that you should use triple packages to send these samples. And always the container that carries your sample, and here we are talking about Mpox. So if it is crushed, if it is swab, that container that holds any of these samples or blood is your primary container. Please do not just put this primary container in your outer box, or what we call sometimes the ice chest. Most often we have these samples just put in the ice chest without any secondary container, and therefore sometimes they are leaked, they are broken, and we are not able to test for you. Please, when you have your primary container, the container that holds your sample, you need to wrap it with a gauze or cotton to cushion it, and then look for another container that is screw capped and it is hard. Then you put your sample inside. Because of the cotton or the gauze, it cushions it inside the secondary container. And when you put in your tertiary box, which because this one you're going to transport with a cold chain, you need an ice pack, so you need an ice chest. You would have to always make sure the secondary container is secured so that it doesn't rotate or it doesn't move around when it is being transported. And therefore, we are able to receive the samples in good shape. The other thing that when you transport by tray packaging, you are doing for us is that you are protecting the environment, yourself, and we, the lab people who are going to work on it, so that we don't get them leaked, we don't get them broken. Please maintain our tray packaging for us when you are sending in these samples. Next slide. And then make sure that your documentation is added. Either you have put it in a case-based form and therefore your transmitter sheet is accompanying it, or those of us who are using the barcodes, or you are using the case-based form, the correct one for Mpox. Please, you put your documentation sheet in a Ziploc bag, and those of us who give it to courier services, put it between your secondary container and the tertiary. There are times that they put these forms outside the ice chest, and when it is being rain is beat it, we get the forms soaked. Some also put it inside the box without any Ziploc bags, and these forms get wet. So please, before you transport your documents, kindly put them in Ziploc bag and put them between the secondary container and the tertiary, especially for those of us who are using courier services, so that it gets into the lab on time. Again, before your sample gets to the lab, ensure that you have entered this in SORMAS, because it is the same channel with which we are going to put your results in. When you enter into the SORMAS, kindly select the right lab so that the lab can see. If you create also a sample, create a case also for the lab so that the lab can see. And as soon as we finish, we can put in your results. Your results will not be sent to you in any form apart from the SORMAS. So please ensure that as you move the sample, the case is also in SORMAS. And then when it gets to the lab and we test, we will put in your results in the same SORMAS. Next slide, please. And then you transport. Make sure that the people we are sending the samples are trained people and they know what to do. We are transporting at 2 to 8 degrees. Please, at 2 to 8 degrees. Next slide. And then all the waste that we are going to generate, we should ensure that we are autoclaving them before we are disposing. So if you are working in the lab, do not let these waste leave your lab without it being decontaminated. Let's do that before we allow these waste to leave our labs or wherever we are collecting these samples. We need to make sure that we are autoclaving them. Next slide. So what have I said since I started? The key point we need to note is that sample collection and the time between collection is important, and it gives us the quality of results that you get. We should also make sure that we collect samples at the right time. We should also make sure that we carry we also make sure that we make contact with the lab before collecting these samples. And then when we are bringing the samples, we notify the lab. Some of us are doing that and it is really helping us. And therefore we are able also to give you a very good result and then also give you results on time. Next slide, please. we need to also make sure that we are ensuring that there are no issues with shipment, and then the type and then the number of samples required are appropriately labeled with the right markers, and the samples also are transported on time. If you are transporting anything or if you are collecting any of these samples and you are in doubt, please do not hesitate to contact the lab professionals. We will be of help to you so that you don't collect and bring samples that are not of good quality, and then we are not able to get you good results. We would have wasted resources. So please always get in touch with any lab professional if you are in doubt of what sample to collect, how to collect it, and how to transport it. And we also make sure that we record all steps and keep the laboratory informed when we are doing these things. Next slide, please. Next. So as a check of all that I have said, we would just have to make sure that we have our PPEs in place when we want to do all these things. And then we have all the logistics that we need before we start collecting our samples. Next slide, please. And then we are stressing on the type of sample. Make sure that you are collecting swabs of lesions and then also crust. The blood and the oral fluid should be when you can't see any of these, then you collect that for the lab. On that note, I want to thank all of you for paying attention. Thank you.
Thank you very much, Dr. Barton, for the insightful presentation on how to manage our various samples. Maybe a few points from what I picked. The results that the lab will give you depends on the quality of sample that you have sent and the time that you also send the sample. And in her presentation, she stressed the need that we need to take the appropriate sample for Mpox. And for the appropriate samples, we are looking at swab of the lesion surface or the exudate or the crust. And that serum or blood should be the last option when you don't see any of the lesions. That is when you take serum or the oral swab. And for the testing, it's not everybody that we are testing. For anybody, any sample to be tested, the person would have to meet the case definition for either being a suspected case, that is somebody who has developed signs and symptoms, or a probable case, somebody with epidemiological link to a case that is showing signs and symptoms. So that is what I picked from a very insightful presentation. So now we've detected the case, we have taken the appropriate samples, we've tested. Now, how do we manage our cases? For that presentation, I would call on Dr. Med Joseph Oliver-Komi, who is a consultant infectious diseases and the director of the Ghana Infectious Disease Center. So, Dr. Oliver-Komi, you have the floor for your presentation.
Thank you. Standing on all existing protocols with respect to your locations, I want to share some few insights with you regarding the clinical care of Mpox. I hope you can hear me.
Dr. Komi, we can see your slides.
Can you hear me?
Yes, and we can hear you too.
Okay, thank you very much. So we'll look at some of the presentations, the typical presentations, the atypical presentations, some factors affecting the current presentations, and whether we are classifying them as mild, moderate, and severe. What do we mean by that? Then Mpox presentation also in special populations. We'll look at some of the management issues and maybe look at some IPC considerations. I realize that most of the things have been said, but just to take us back a little. So in 1958, everybody is asking, why are we worrying ourselves with Mpox? The first case of Mpox was diagnosed in 1958 in Denmark, in monkeys that were being kept for research. So between 1958 and 1970, nothing, no Mpox issues were being discussed. By 1970, we first had the first human cases of Mpox in the DRC, the Republic of Congo. Then there was a lull in Mpox presentations until Nigeria had an outbreak somewhere in 2017, and then the current outbreak that we have started in 2022. So yes, Mpox has been around from 1958. It's not new. So let's keep that at the back of our minds. Mpox, we say, belongs to the orthopox viridae. So the others are cowpox, Mpox, smallpox. At least we know that smallpox is eradicated, but Mpox is what we're dealing with at the moment. And initially, we were told that there are two clades. So clade 1, also known as the Central African clade, and then the clade 2, which is also known as the West African clade. Over time, Mpox has undergone mutations. So initially, we were talking about clade 1, clade 2. Now, in clade 1, you have subclade 1A and subclade 1B. In clade 2, you have subclade 2A and 2B. So we're saying that some of the mutations have enhanced the human-to-human transmission that we are thinking about. Also, there's been some form of historical spread. So we knew that Mpox was largely zoonotic, limited human transmissions. However, we are seeing a lot of sustained human-to-human spread, particularly also in our sexual networks. Like I said earlier on, we had clades. We all knew clade 1, clade 2. Now we have subclades. And this is reflecting the adaptation to the human host. And now Mpox was first confined to Africa. Now Mpox is reported over 110 countries. So it is not only Africa. Elsewhere, people are also looking at Mpox. This is just to show you that when we talk about the clades. So we say that it's usually transmitted, and I'll just highlight some few things here, through close, sustained physical contact. Through what? Close, sustained physical contact, okay? Yes, there are sexual contacts in the current multi-country outbreak. And I always ask, if you can have sex without coming into contact with the other partner, then your guess is as good as mine. I am not saying that Mpox is a sexually transmitted infection. All I'm saying that Mpox can be transmitted or acquired through sexual contact, because when we have sex, we come into contact with another person. It is critical then that clinicians take a detailed sexual history of the patient with a suspected Mpox and also consider other STIs. If Mpox is suspected, the healthcare worker must wear appropriate PPE and perform a complete physical examination. When you suspect Mpox, wear appropriate PPE and perform a complete physical examination, which includes the skin and the mucosa, so oral, genital, anal. Mpox should be considered when a clinician is trying to determine the cause of a diffuse or localized rash. So let's all keep that at the back of our minds, even as we talk about Mpox. Yes, we know that the disease lasts between 2 to 4 weeks, and the severity depends on the person's immune system and also the clade that is involved. So for people who are immunosuppressed, they tend to present with a more severe form of Mpox as compared to people with good immune systems. And we know also that clade 2 is milder as compared to clade 1. So this disease Mpox, how does it present? We talk about the invasion phase. That's between the first 5 days. That's when the patient may present with a fever. And the fever, I keep on saying, for those who have had Mpox, talk about the fever greater than 38 degrees Celsius and is present in close to about 85% of cases. There may be some headaches, chills, lymphadenopathy, which is one of the key distinguishing features between Mpox, smallpox, and chickenpox, and also measles, which are also differential. And then the issue of the myalgia and fatigue. Then there is the rash. The rash presents in about 97% of cases, which appears sometimes a day to about 3 days after the onset of the fever. Key thing is it begins from the face and spreads to the trunk and the limbs. Mpox rash is often painful and non-itchy in the initial stages. Often painful and non-itchy in the initial stages. So like I said earlier on, the rash presents in sequential. So if you think about chickenpox, we are all taught that when you have somebody who has chickenpox, the rashes appear at different stages. So you could have a person with chickenpox and you have some macules, you have some crusting lesions, you have some other target lesions in chickenpox. However, with Mpox, the rash presents in the sequential stages. So may start as macules, progress to papules, may progress to vesicles, or pseudopustules to vesicles. Then they may start crusting and scabbing off, and then you have new skin forming. So as compared to chickenpox, the Mpox rash presents in sequential stages, and this may occur over a 2 to 3 week period. The lesions may range from about 0.5 to about 1 meter in size, from a few lesions to sometimes more than 1,000 lesions in one person. We say that the lesions are firm because they are deep-seated. And oftentimes they may develop amplification, so like a dimple, a dot on top of the lesion. So think about these things when you think Mpox when you are seeing such lesions. Where can you find the lesions? On the skin, face, trunk, the limbs, including the palm of the hands and the sole of the feet, anal and genitals, oral lesions, and also some eye lesions when it affects the conjunctiva. I've mentioned this earlier, and I said oral ulcers are common, and they affect a person's ability to eat and drink, which may lead to dehydration and sometimes malnutrition. And the rectal swelling and tenesmus are found in some cases, so the ones with enogenital region. And the proctitis may be the main presenting symptom. And we have had some of our cases, the earlier cases, presenting to the hospital, not because they had a rash in around the genitalia, but because now the rash in the anus was quite painful and they couldn't sleep. And that's how come they presented in the facility. So let's think closely about this also. So somebody may come and say, pain, I can't sit down. I'm not able to, I've had constipation for some time. Please examine and you may find something interesting. Still talking about the rash, I spoke about this earlier on. The fact disconnected. Hello? Hello, please, can you hear me?
Yes, Dr. Comey, we can hear you.
Please continue.
Okay, thank you very much. So I've spoken about this already. The face, about 95%, conjunctiva and cornea, close to about 95%, oral mucal membranes, the genitalia, palms, and remember I said that it may take about 3 weeks for the rash to develop up to crusting. And these are some of the lesions that we are seeing. So you can see in the palm over here, the amplification I spoke about. On the face here, you can also see the amplificated lesions over here. And this is also Mpox on the persons, but this you call severe Mpox because these are in the hundreds of lesions. Then these are also lesions we are seeing in the current outbreak. So somebody's palm, and you can see the genitalia. So sorry about if you haven't had lunch already, but as you can see, if this person presents to you, this is Mpox lesions. These are also Mpox lesions, some crusting superimposed bacterial infection, Mpox around the scalp. So yes, the rash we see can be quite disfiguring, and that's when patients may present to the hospital. Here, I'm just trying to talk about some of the differentials between Mpox, smallpox, and chickenpox. So when we talk about the fever, almost all of them, it takes some days before the fever and the rash develops. The rash appearance may be still having macules, papules, but for Mpox, we say that they all appear around the same time. So from one stage, from macules to papules, and they may be implicated in some stages. The Mpox rashes, slow and more dense on the face and the extremities, may be present on the palms, and the rash duration may take close to 4 weeks as compared to shorter durations for the others. Lymphadenopathy common in Mpox as compared to the others. And mortality, 10% and up in severe cases for Mpox, but very quite severe when it comes to smallpox. So at least people looking at this might say that Mpox, after all, is not a very deadly disease. The differentials, and for almost all of us, we need to think about varicella zoster, chickenpox, herpes simplex, primary or secondary syphilis. It's also important. Disseminated gonococcal infection. For children, think about also hand, foot, and mouth disease. Chancroid could also present in a similar way. Scabies, measles, some viruses, chikungunya, dengue, and arboviruses may also present with a rash. So you may have to have that at the back of our minds. And also molluscum contagiosum as also a differential. So yes, we spoke about this earlier on just before this. So clinically, using PCR samples of skin lesions. And this is just to rehash what Dr. Gifty just said. No sample taken during the incubation period. During the rash stage, you are drawing samples of the lesion fluid, roof or the lesion crust. And when the person is recovering, we think about taking serum for antibodies. So how do we manage Mpox? Remember, I said that Mpox is not a deadly disease. It's largely self-limiting. Patients may require just symptomatic and supportive care. And I'm sure you heard from the presentation that most of our current patients are undergoing home care treatment. So the major principles of management: 1, protection of the compromised skin or the mucous membranes; rehydration, which is very important; alleviation of the distressful symptoms. If the person has so much pain in the anal region, around the genitalia, or the ulcers are quite painful, make sure we take care of the pain. Provision of nutritional support. Then there will be some people with complications. So some of them may have superimposed bacterial infections and may end up with sepsis. We may have to deal with it. Psychosocial support, very important, because sometimes there's stigma associated with Mpox. Reason why we move from monkey to Mpox. So we also need to think about this, that once somebody is diagnosed with Mpox, and all of a sudden you are wearing all kinds of things to manage that particular person, there's some form of self-stigma by the patient. So we need to really think about the psychosocial support that we give to this patient. And then if there are comorbidities, so somebody might have hypertension, uncontrolled hypertension, you also find Mpox. Please deal with the uncontrolled hypertension. The Mpox is self-limiting and will resolve on its own. It doesn't mean that because the patient has Mpox, lesions all over, and patient says I'm hypertensive, whilst monitoring that patient, BPs are not checked, sugar is not checked. Please manage the comorbidities that the patient also present with. So supportive care, IV hydration, analgesia, and please use a WHO stepwise. You may start with paracetamol. If it's not working, go on to your NSAIDs, and sometimes go up to morphine, just to make sure that we take care of the pain of the patient. I'm going to mention this here, and a very short one, in terms of the antivirals. There are no specific antivirals for Mpox. most of these antivirals were developed with smallpox in mind or other ortho mixopox viruses. And it's said that it was good for smallpox. In animal models, it's worked for some Mpox cases. So tecovirimat, cidofovir, and brincidofovir have been used in trials. Yes, it's shown some promise, but compared to placebo, it didn't show any significant. So nobody actually may be pushing for antivirals at this stage. But there is a place for antivirals, especially in people with severe Mpox who are immunosuppressed. In that case, antivirals may be considered as part of the management. Note, I didn't say that in the current outbreak, what we are giving are antivirals. It's information for us so that just in case anybody is maybe answering an MCQ somewhere later, you could also add it to it. But in the current situation as a country, we haven't spoken about tecovirimat at the moment. So these are, I'm sure we'll share the slide. So if you are managing the fever, the skin infections, eye infections, there's supportive things that we will have to do regarding these patients. So Mpox in children. It's not only Mpox in adults, Mpox in children. So the current situation, 10 out of the 43 cases or confirmed cases that we have are children, ranging from 5 months to 17 years. These have generally been mild with very few lesions. I'm sure somebody's asking, what may be accounting for this? Why are children also getting Mpox? Remember, we say it's a contact. Some people hold children. Some people live in communal settings where this person carries your child. Another person carries a child, is passed on from one person to the other person. So it could be possible. Children play together. So one child may have it through the contacts or sports or whatever. It also spread to other people. So yes, it's important that we consider Mpox in children. And kindly, out of the 43 confirmed, 10 are children. So we say that Mpox can affect children. May present more severely in the younger age groups. Children less than 8 years old, especially those with underlying health conditions, are at risk of higher or severe outcomes. And we say that sometimes children are the ones we need to target most when it comes to maybe in hospital care for them. They have the potential for abscess formation when they tend to develop the sore throat and other things. And then they may also present with serious complications, including encephalitis, pneumonitis, blindness, and secondary bacterial infection. Children younger than 5 years are more likely to die from Mpox than all other age groups. So we've done with the children. Mpox in pregnant, breastfeeding, postpartum women. Yes, pregnant women and breastfeeding mothers are not uniquely susceptible to infection, but their health status can affect outcomes of both mother and child. So pregnant and breastfeeding women diagnosed with Mpox should be managed in consultation with infectious disease specialists and obstetricians. Infected pregnant women may experience more severe symptoms, increasing the risk of complications such as preterm birth or miscarriage or fetal loss. Fetal risk, we see that there's a potential for adverse outcomes, including congenital infections. But then the data is not still clear on this. The risk may vary depending on the stage of pregnancy during infection. I'm sure somebody's asking, have we seen a pregnant woman during this current outbreak? Yes, we have a pregnant woman during this current outbreak. So yes, apart from knowledge that we are sharing, we are also experiencing these things in real time. Mode of delivery. If a pregnant woman has Mpox, the mode of delivery, as we compare vaginal versus cesarean, should be an individualized based decision. also based on the clinical condition of the mother and the stage of the infection, fetal well-being. If you have active lesions, then we think that cesarean section or cesarean delivery may be considered to reduce the risk of transmission to the infant during the delivery process. Timing of the delivery. If the mother shows signs of severe illness or there are concerns of fetal distress, then we think that timely delivery may be necessary whilst prioritizing the health of both mother and child. Transmission via breast milk. There is insufficient evidence, that's from literature, but it's been documented from DRC. Yes, we've been asked to produce more, more data to that effect, but it's been documented that breastfeeding or breast milk may or has the potential maybe of transmitting the infection. Yes, they found it there, but as to whether it can cause an infection, more research is being done. So caution is advised as the virus is present in the body fluid. So we need to think through this carefully. If the mother is symptom, remember that if you are breastfeeding, there's skin-to-skin contact. So it might not be in the breast milk, but then the baby could pick it from sucking the breast to take the milk. So let's think about breastfeeding options during the time of a mother who has active lesions and also just had a baby. Postnatal risk. That's talking about the skin-to-skin contact or when they have to hold their babies. So infants should be closely monitored for any signs of Mpox or other infection. If the symptoms develop, they should be evaluated promptly. Like I told you earlier, we had a 5-month child, we've had a 2-month, we've had 2 years, 8 years, 9, so up to 17 years. So healthcare providers should offer guidance and support for breastfeeding mothers diagnosed with Mpox, okay? It's very important. What are the take-home messages from managing pregnant, this special group of people? Individualized care, timely medical intervention, and adherence to IPC control guidelines are crucial for optimal outcomes. Collaboration between the obstetricians, infectious disease specialists, and pediatricians can help provide comprehensive care in these cases. I'm moving towards one of my favorite topics in Mpox. We say that all the cases, or majority of our cases, are in isolation. Principles of isolation. We say that once a person is suspected or confirmed to be infected with a contagious disease, that person is isolated. In Mpox, before we isolate or suspect anybody, we need to critically apply the case definition Dr. Arthur spoke about earlier on. So the key thing here I want you to notice that cases remain in isolation until their skin lesions have crusted, the scabs have fallen off, and a fresh layer of skin has formed underneath. This could take you close to about 21 days of the patient in hospital or in isolation. And this is something I want us to remember, that the cases remain in isolation. And remember, isolation could be in hospital isolation, or we could do isolation at home. So what do we consider? We are talking about IPC and WASH measures for home care and isolation for Mpox and resource, and this is a WHO guidance. So determine first if the person with Mpox can be cared for and isolate at home. Thereafter, there are IPC measures for the healthcare workers, the caregivers, and the persons with Mpox during their home care and isolation. So I'll try and illustrate a few. Deciding on home care, the key considerations: think about clinical severity, think about the presence of complications, think about the care needs of the patient, think about risk factors for this patient, access to referral for hospitalization if the condition deteriorates, and availability of support if needed. I jokingly say that you tell somebody who lives alone that he must be in home isolation. He says, yes, I am going on home isolation. Then you go to the market to buy foodstuff and you meet the person who is supposed to be in home isolation, also in the market buying foodstuff. And you should not be worried because that person lives alone. Where is the support? If there's no support, then why then do you agree that this patient should be in home isolation? If there's no support, this person definitely needs to be in isolation under your care. And you need to provide for this person whilst the person is in an isolation under your care. Risk factors. We always say that children under 5, pregnant women, people who have co-infection with HIV or are immunosuppressed or uncontrolled diabetes, heart failure, when they develop Mpox, these ones should be considered for in-hospital isolation, where we can monitor them as compared to home isolation. So if the risk factors for severe disease are there, person is immunosuppressed, it is recommended that we do in-hospital isolation as compared to home isolation. Please, let's keep these things at the back of our minds when deciding. Then, these are things I just want to share a little. So, WHO says that the person with Mpox should remain in a separate, well-ventilated area. That means a separate room or an area separated with a curtain or screen and away from other household members, pets, and shared areas of the home, unless that person needs to do an urgent or essential activity, such as obtaining care at a facility or getting exercise or fresh air. So it means that even when we say you are doing home isolation, it means you are not going to places where you will mingle a lot with people. But if you are the person who feels bored in the room, you can go out and do your jogging or your walk, but make sure that your leashes maybe are covered and do not get into physical contact with any body. These are things that, and I'm sure when we share with you, we can read on our own about the IPC measures that we can put in place. For IPC to the patient, we say that cover your lesions. For people with TB, we say you cover your cough. For Mpox, we say cover your lesion. And cover using your own cloth and wear a mask, a medical mask or a fabric when you are around others, okay? Separate from others. If no designated room in the house is available, identify your own space. Avoid touching the environment. So places where people normally will touch, and we say that the person with Mpox should keep clean hands, meaning as often as possible, washing your hands with soap and water or using alcohol hand rub. Do not share personal items. Some of our people on the field are telling you that there were some contacts they followed and they are sharing the same sponge, sharing the same towel. If we do that, definitely, if I have Mpox that we are sharing, in chickenpox, we don't even share things. So the same principles apply here in Mpox. The other key thing that we need to note, it's about linen and how we handle the linen. Remember, we said that as one of the ways of people getting Mpox, when we spoke about respiratory droplets, we also spoke about fomites from the beddings or clothing. So if you are going to launder these things, what do? We say preferably to use hot or warm water with detergent or chlorine to more or less wash. If you can use a washing machine, fine. If not, then maybe you need to wear, if it's a child and you are looking after the child, then we feel that you should wear some protective clothing before you do that. But it's also advisable that if the person in home care or home isolation is quite strong, then the person should do his laundry and everything together. And here you can see that wash in a mixture of warm water You can also use Dettol, soak for about 20 minutes, and then you can wash. So these are things that we can do. Do not clean linens in communal washing areas or in water sources such as rivers. That is something we need to do when we are telling people you can do home care. And hang linen in a clean or dry space, preferably in direct sunlight until it is dry. This is information we need to give to our patient. There is no need for us to go and do spraying. Oh, I beg you. No spraying matter here. Okay? Clean surface with soap and water, then use a disinfectant. Do not sweep their rooms. You can always use a damp mop to clean their rooms. So, if you forget everything in this lecture, we are saying that most of our patients are at home. So assess if the person with Mpox is suitable for home care isolation. Persons with mild uncomplicated Mpox may be isolated and receive care at home. Children under 5 years old should be cared for in a health facility as they are considered at a higher risk for complications. We spoke about if there's no spare room in the house, a person should designate a specific area where he or she will remain in that house so that they can still share their place, but make sure that they don't come into contact. Persons with Mpox and their contact should practice frequent hand hygiene and cleaning and disinfection of the environment. Healthcare workers should have training and require supplies, PPE, alcohol-based hand wraps, prior to entering the households of persons with Mpox. And it's here that if these things are not available, when you go on the home visit, try and maintain a 1 meter distance between you and the person with Mpox. We should ensure that people have access to safe water, sanitation, soap, and waste disposal for persons with Mpox and their family members when we talk about home isolation. So let's keep that at the back of our minds. I'll be ending soon. Let's look out for these in due course because I'm sure they are coming up. Is there reinfection? So suspected Mpox reinfection, probable Mpox reinfection, confirmed Mpox reinfection, Mpox persistent infection, and Mpox relapse. Today, we're not going into the details of this, but these are things I want us to think about. Yes, there's Mpox reinfection. This is a case report of about 8 cases of reinfection that have been documented so far. So thank you very much for listening to me. And I'm sure I'll check the Q&A if there are questions there, or when you have the question time, I'll be here to answer your questions. Thank you and over.
Thank you very much, Dr. Komi, for the insightful presentation. I think we are far behind time, so my take home or takeaways, I would suspend that to the end. Now we've been able to detect the case, tested, manage the case. How do we communicate with the case, the community? How do we even give out information to the community? The next presentation would give us some tips on how to be able to communicate in terms of Mpox, the various strategies that we can use. So I would call Mrs. Bridget Enim, the Deputy Director, Health Communication, to make that presentation. Mrs. Bridget Enim, I don't know if you can hear me. If you can hear me, then please over to you. Thank you.
Yes, I can hear you. Good evening, Dr. Tawa. Good evening, colleagues. So I make this presentation on how we can communicate the risk that we face to our communities, whether we work in a hospital facility or in a public health setting. Next slide, please. So this is the outline that we will be going through. And then specifically to our learning objectives, next slide. We want to understand how RCCA can be done in the hospital and also in other health facilities. And also in risk communication, we are interested in what target audiences we are communicating to and what their needs in terms of communication are. And then identify the activities that we can carry out to prevent the spread and to manage the fear. And then coordination with public health authorities. At the end of this session, we expect that we would have discussed this and we are able to carry that out. Next slide, please. So by way of introduction, we're saying that risk communication has to do with the real-time exchange of information, advice and opinions between experts, which is all of us on this call, who face, and people or communities who face a hazard or a threat to their survival, to their health, to their livelihoods and their social well-being. And risk communication, as we identified from the beginning, is one of the core capacities of the international health regulations. Risk communication, again, is a science-based approach for communicating effectively when there are situations that are of concern to people. People are emotionally stressed. It is an area that risk communication comes in strongly. Next slide, please. So risk communication is multidisciplinary and it uses a mixture of approaches. So communication and engagement approaches. So we are looking at media communication, social media, mass awareness campaign, health promotion activities, stakeholder engagement, and community engagement, which is very key. So risk communication essentially ensures that everyone who is at risk is able to take informed decisions. So we have heard all there is to hear about Mpox. How do we communicate to the communities that are affected to be able to take informed decisions to protect their health, to take preventive and protective actions that would mitigate the risk that they face? Next slide. So the ultimate purpose, as we have said, is to ensure that the community is able to take informed decisions to mitigate the effects of a threat. So essentially, all we do in risk communication is that the information that we have gathered in here today and you already, we should share that information between us as experts and the communities through various communication approaches, including engagement, which will further allow them to take the decisions that will protect their health, take the actions that would lead to the reduction in the transmission that we are currently seeing. Next slide. And coming to community engagement. So we've spoken about risk communication. We're now moving to community engagement. These are two distinctive concepts. However, they come together to make our response efforts better. So for the community engagement, we are looking at involving people in understanding the risks that they face. All of this knowledge is with you, the health professionals. How do we engage the communities for them to understand? How do we involve them so that the response activities that we are churning out there is acceptable and workable for them? If it's not acceptable for them, if it's not workable for them, we're telling people to be in isolation. Dr. Kwame was just elaborating the ones that qualify for home isolation. So if I have to do home isolation and it's not workable for me, you will definitely meet me in the market and we'll all be buying cassava together. So the goal of our community engagement is to empower the communities to develop shared leadership through the response period. Next slide, please. So for us as health workers who are in this Mpox outbreak, why do we need to work with the communities? The outbreak that is happening, it is happening in the communities. That is where it's happening before it comes to our health facilities. And therefore, we should see that the community is at the heart of the outbreak, and therefore we cannot manage this outbreak without engaging the communities. We should see the communities again, as equal partners in developing the response, because all of this is for them. And therefore, as we said, it should be acceptable and it should be appropriate for them. We need to be able to do this so that we are able to build and maintain trust, which is very critical when it comes to risk communication. If we don't have the trust of the community that we know how to manage this, we have seen this before, we know what it takes to bring it under control, then the response would be difficult and it will take a long time for us to be able to break the transmission. Next slide. And therefore, we are saying that health workers must understand how our communities perceive the situation. So how we are seeing this outbreak, the way we are seeing it as professionals and as experts, it is definitely different from how the communities will see it. And Dr. Komi mentioned something. So why are we worrying people about this Mpox? Because the way where you sit is different from where the community sits, even though at other points in time, we are also community members. We need to understand that so that it helps us going forward. In a few slides, we will show why we need to see how the community perceives the risk that they face. And in risk communication, perception is very key. How I see it, how you see it, there has to be some level ground so that we are able to work the solutions together. And how communities would interpret the risk they face as health workers, we need to understand that if their risk perception is low, we can be sure that we can do all the engagement, all the community entry things. But once the risk they see is low, they will not come to the level that we want them to come to take the decisions that will protect their health. We again have to be able to feel about their ability or capacity to mitigate the risk. So I am being put in isolation. I have to be in whether home or in hospital. How does it affect my livelihood, for instance? So we need to be able to see if they are able to practice what we are preaching for them to adapt. And then how our communities are impacted by situations related to the emergency. Not necessarily the emergency itself. So there's Mpox outbreak. Yes, as health authorities, we are worried about it. But for the people who are affected or infected as well, it is not just about the emergency. It is how it affects them, the situations in which they live. Because if I have to do isolation for 21 days, what happens to my work? How do I go to work? Those are key things as well. Health workers, we should keep at the back of our mind so that we can communicate for us to be able to work with our communities. Next slide, please. So why does risk communication and community engagement matter? The importance of effective and timely communication is particularly high during an emergency where the situation is rapidly evolving and there's need for information is particularly high. So Mpox is here. The education has started at all the levels. We have to keep it up because people want to know. So they are calling you on radio. You need to provide the useful information, accurate information that we have. The perception of risk among affected population, we have mentioned this, often differ from the experts. Effective risk communication can help bridge this gap by determining what the people know already, how they feel, and what they do in response to the outbreak, as well as what they ought to know and do to bring the outbreak under control. So we have to be in our work in communicating this, come from what is known to what is unknown to them to be able to bridge the gap to ensure that they adopt the protective behaviors. Therefore, effective risk communication can help transform and deliver complex information so that it is understood, accessible, and trusted by the population. So the information and the knowledge sharing that has gone on this platform is very scientific, very technical. This is obviously not what we should be carrying to our communities. And when we say communities, the geographical communities, and for those of us who work in hospital facilities, the professional groupings, the clients, the patients, relatives, all of them. How do we translate this information to ensure that they understand and they come along with us? Next slide, please. So if we are able to do risk communication, why it matters is that it would promote the rapid outbreak containment so that we are able again also to prevent diseases and avoidable deaths, and also to reduce possible disruptions to livelihoods and the entire society. We don't want people in hospitals. They need to be able to go out there and work for themselves and for Mother Ghana. Again, it is important because it will help prevent panic, because we will be giving out clear and accurate information devoid of the many technical jargons in a language that is accessible to the communities that we are communicating to. It will also help us to reduce the stigma that is associated with the condition, and a very key point to maintain the trust in the health system and to ensure that there's continuity of essential health services. The fact that there's Mpox still means that other conditions are on. Our essential health services should continue. So people should have trust in our health services to be confident to still access services in our facilities nationwide. Next slide. So then for those of us in the hospitals and even for the other health facilities, we know that typically in Ghana, our health seeking behavior is not the one that comes directly to the hospital. They would have moved round before, when it gets critical, before they check into a healthcare facility. At the time they get there, they're expecting that we have the accurate information, and therefore we should ensure that we share this information with them. The hospitals are seen and all our facilities are seen as frontline sources of information. By the time they come, as I'm saying, they would have gone to places and is not resolving. So once they come to you, is an opportunity for us to engage them and ensure that they get the right information. And our patients and our clients are relying on the messages we're giving them, as well as on us as professionals. So in risk communication, we say that the message and the messenger are equally important. So the messenger is you, the health professional, carrying the message. How trustworthy are you? Such that when you give out information, when you empower people, they will trust you to be able to put them to where you want them to be. Again, it will foster trust between us healthcare providers and the communities as they carry on with their adoption of protective behaviors. It also helps to remove panic, and it helps us with the early detection of cases. So people are going round and round. Why are they not coming? If the information is out there that if you see fever, if there's a rash, please come to the hospital. If there's heightened awareness, then people would come out, and then we get the early detection and ensure IPC is also adhered to. Next slide, please. Still a bit more on why RCC in hospitals is important. In our hospitals, the leadership of the hospitals are already aware of the situation. We need to involve them so that we have their buy-in and the support, and all cadres of health staff. So we have our drivers, our orderlies, they are being asked to clean. As patients are there, the security people are there, and they are hearing information. But all of these trainings that we are doing, we leave them out. But there are sources that we can get information as to what is even happening in the communities. And therefore, we need to involve all manner of cadres within the hospital and also within the communities, involving vulnerable populations, including people living with disabilities. Our messages should be tailored to the particular audience so that it sits down well with them. Again, we should use multiple channels. No one channel is superior to the other. It depends on your audience and what works best already within the facility or within the community. As part of the RCCE things, we should ensure that we get feedback, because we should be able to, as part of our RCC, listen to what the community is saying, what their concerns are, including through formal and informal means. That's why I was alluding to even security people picking up information within the hospital facility and also within the community's informal settings as to what people are talking about. There could be people hiding in their rooms. And through these feedback mechanisms, we should be able to pick those things up and respond appropriately to help break the transmission. To be able to do all of this, we need to build the capacity of our health staff. So this knowledge that we have gotten today and previously, we need to see how we cascade this training for our other colleagues to also benefit. Next slide, please. So the impact of our RCCE would lead to improved transparency. Everybody in the healthcare facility is involved. Our communities are also involved. It would help foster trust. We can't say trust enough, because in RISCOM, trust is key. It will also help to enhance patient compliance as to the advice that we're giving them. It will also help foster stronger community relationships, because if we are planning together with them and taking their concerns, they would know that we are not just handing them down information, but we have their concern at heart. And beyond the outbreak, then we still have the relationships that we would need going forward with our work. If we do very effective risk communication, it helps us to reduce misinformation, because you're picking up concerns and you need to respond to them appropriately to ensure that any void, any inaccuracies in the information out there is corrected, such that misinformation is curtailed to the barest minimum. And obviously, there will be increased healthcare utilization such that our facilities will still continue to run for improved health outcomes. Next slide, please. So in our risk communication, we should be able to identify our key target audiences. So for the hospital facility, who are our key target audiences? Our healthcare workers, both clinical and non-clinical. What do they need in terms of their communication? Appropriate use of PPE. Earlier presentations have discussed that the case reporting forms, the lab things, all of that, what they need to do is what you're communicating to them for them to know. And once they have the appropriate information, then they will be able to respond to rumors and misinformation appropriately. For our patients, what is the transmission? How is Mpox transmitted? What are the signs and symptoms? Basically, that is all we are telling them, not the big things that the earlier presenters have mentioned. They do not need that, they won't understand, and they will not come along with us. So the basic things is what they need. Our media partners, we cannot leave them out. They help us to amplify our messages. However, we should watch how we engage them. In the facilities, in the regions, there are spokespersons who are mandated to speak, especially to numbers of cases that are out there. And at this point, let me plead with us. For the Ghana Health Service headquarters, now there are weekly updates that are going to be given. And these updates are going to be given on Tuesdays, unless it is changed from the higher management level. In this presentation or in this session, the confirmed cases have been given, but that official information has not come out. So please, when we leave this meeting, wait till the official update in terms of the numbers are out. What we can do as technical persons is to continuously educate, inform, empower, but not be speaking to the numbers. Let us leave that to the official spokespersons who have been mandated to give out the numbers, so that we are, as a service or as a sector, speaking to one thing and not different issues at the same time. Next slide, please. So the key messages to communicate what is Mpox simple and how it spreads. That is what we should be telling them. It is said that as experts, we talk in an inverted pyramid. So we are giving the background, the rationale, problem statement. In RCC, this is not your thesis. So the basic things go straight onto the facts. What is Mpox, how it spreads, the symptoms to watch out for, what can we do to prevent it? And then as part of it, encourage timely health-seeking behavior, and also how stigma and misinformation can be addressed. So basic, straight to the point, no jargons, and your message should be in a language that the community, be it within the hospital setting or within the community, can identify with and associate with. Next slide, please. So this is specific to hospitals. What activities can RCC activities within the hospital setting? We're focusing on the hospital, not because the communities are not important, but in the communities we do that well enough. But just to throw emphasis on the hospital, but even then it can still go for our communities. We have posters, flyers, and audio visuals that have been developed. We're saying that these should be displayed at vantage points within the facility and in the communities to advantage points. And then we can use staff briefing, clinical meetings, and various WhatsApp groups to share information on the current outbreak and how it is being managed. The audio visuals in various languages have been produced. Currently, what we have are audios, so jingles in various languages. I think about 7 languages we will share with you, so that in the hospital PA systems, in the communities, on our pickups, the horns that we mount, these messages should be playing and bringing information and empowerment to our communities. One-on-one education during patient consultation is key, and all our various service delivery points, another key thing that we should be doing. And then our media friends, they are a major stakeholder. We should not leave them out. And then documentation is key. All of these activities should be documented as part of our routine documentation that we do in the health facility and within the communities. Next slide, please. A few slides on misinformation, on how to help us to address it. Rumor, we are saying, is not always false. So when you hear a rumor, don't be quick to ignore it, because rumors can be true or false. For our misinformation, it is a false or inaccurate information that is meant to deceive the public. And most times, we ourselves as healthcare professionals are guilty of this. So we hear information, we do not verify, and we share, but the content could be wrong. In that instance, what we are doing is to misinform, but not with any bad intention. For disinformation is also false information, but in this case, it is deliberately engineered or put together by people to deceive, misinform. And the intent is to cause harm, sometimes to get fame, and sometimes to get money. So these are the clear differences in these technologies. So who are the people who start rumors? We're saying that they are people who have contradicting invested interests. They could be health workers, as I said, traditional healers. They're making money out of the rush that somebody has, and then suddenly you are saying these people should not go to them again and should come to the hospital. Obviously, they would also counter, because for them it is about livelihoods. The press, politicians, anti-vaccine lobbies, religious and cultural groups, because it is their belief they could start a rumor that would have a negative effect on whatever intervention, in this case, the Mpox response activity that we are having. Next slide, please. So what will cause a rumor so that we watch out for it and then it doesn't happen? Inadequate or inaccurate knowledge or information. If there's a void, then obviously people will fill it in. This training was put together because we are responding to an outbreak. Health workers needed to be trained. So the information is provided. In the same way, we have to share it with the community that is at the heart of this. Sometimes too, communities have issues of mistrust in government institutions, not just health. And therefore, any response activity, any intervention, people begin to read meanings into it. Again, people would have past or negative experiences, poor treatment from our staff on things that had happened in the past. And therefore, they have been put off for any response activity. Ulterior motive, desire to be famous. Now everybody wants to trend. They want to be viral. So they are putting things out. They think that when you trend, it's not the thing. When you trend, you make money out of it. For those who are making social media a big thing. Therefore, people will do it to be famous. Coincidental events can also cause rumors. So having known this, then as we go on engaging our communities, we need to ensure that we are addressing these to ensure that these rumors that would lead to disaffection would not happen. Next slide, please. So how do we address or how do we respond to the rumors? We have to analyze the situation. We have said it could be true or false. So once you hear a rumor, you need to verify the extent of the rumor, how the channels that have been used to put out the rumor, and what the motive is. And in most times, it is lack of information, unless it is disinformation that is deliberately put out. Therefore, if it is lack of information, you have been empowered. You have all the technical know-how to be able to speak to it, to ensure that the sources of the rumor is giving the accurate information. Again, to respond to rumors and address the misinformation, you need to turn the rumor around. Go to the source. To quench a fire, you need to hit the source. Otherwise, you are just playing around it. And you do not go to address a rumor by repeating the rumor that you have heard, especially if it is misleading or misinformation. So you know what rumor you have heard. You turn it around by giving the community or the target audience the information, the correct and accurate information that you have as a technical expert. Next slide, please. We need to train. We have spoken about that so that all the cadres of staff are able to give out the correct, tailored information for the particular target audience by promoting positive key messages. Mobilizing the community is very key. Within the communities, there are influencers who are already existent and they work and people trust them. Let us use them. Within the hospital settings, there are people. The hospital management is there. Let us use them to ensure that we get everybody to come along. Advocacy, a very key tool to help us turn around the rumors. If there's a rumor and a high-level management person speaks to it, then we can be sure we can manage it appropriately. Next slide, please. We need to monitor all of this that we're doing. We are picking patients' concerns to help us to address the rumor. So we need to track all of this in our hospital facilities and even other facilities. We have the suggestion boxes. If we should open the suggestion boxes. It shouldn't just be there. And then whatever it is that people have put in there, we address those concerns. This also helps to foster the trust that we so much desire for this response and beyond. Next slide. the coordination with the health directorate, very key. This is a public health emergency of international concern. When we pick up cases, we should be able to link up with the appropriate health directorate and report. The SBC materials or IENC materials, we have shared a few copies, in fact, all that we had with all regions. Therefore, we are to contact our regional health directorates to get copies of these materials. And if there's misinformation that we see, after our assessment, this is going up, let us kindly link up with the appropriate health directorates, be it the district or regional or national level, to ensure if there's a need for a response, then it is giving out using the appropriate channels. Next slide, please. So I'm about ending the presentation. These are the available materials that we have. Just simple things that we have put out there. Having said that, new ones are being printed to ensure that we get more copies to our various regions and to the facilities. Next one. So we have these posters. We have a discussion guide. Next slide, please. We have this discussion guide for those of us who would be doing radio discussions, for instance, TV discussions, and other forms of engagement. This is a very useful tool that we can use. And we'll share all of that as part of the presentation package. Next slide. And then we have the jingles that I spoke about that can be accessed through this link in 7 various languages, including English language. So colleagues, this is what we want to share with you. In summary, we're saying that effective risk communication within hospital settings and in our communities is critical to our Mpox outbreak response. We need to provide clear and timely and culturally appropriate information. Remember, we said it is the timely exchange of information. And I know we have all started. We have to be consistent, keep at it to encourage early care seeking behaviors, combat fear and misinformation. We need to engage all our staff and our patients and the various stakeholders to foster trust. And then embedding risk communication and community engagement as a routine component of healthcare delivery not only strengthens our outbreak response, but also enhances our overall public health resilience. On that note, I thank you for your attention.
Well, thank you very much. Thank you, Mrs. Bridget Neem, for the very insightful presentation. I am certain that colleagues have noted a lot of things, particularly on the drivers for misinformation. And so we should be on the lookout because we learned a lot from COVID on how these can impact negatively on our response efforts. We are way behind over the time we are targeted to close at 6 p.m. Fortunately, we've had quite a number of questions answered. And so we will probably give 4 August presenters some 5 minutes each, or maybe less, to address any burning issues. But before then, I want to acknowledge the presence on the call of the Director General of the Ghana Health Service, Professor Samuel Kaba Akorea. Thank you very much, DG, for making time to join us this afternoon. I'm not sure if you'd like to say anything, but it will be good to hear your voice. So, Professor Kaba, I'm not sure if you'd like to pass a comment. Thank you, sir.
All right. Thank you so very much. I thought they would take the questions, then we'll wrap up. But let me take the opportunity. Am I being heard, please?
Yes, please.
Okay, good evening to everybody. I know it's been a long day because this started around 4 and it's 6:20. I've been on throughout. And I must congratulate all the presenters and then all the participants who have taken time to join to know more of Mpox and to support us in this fight. We will look at how best we really make this and repeat it again time to time so that people will be well updated. It's been a pleasure for me to see how the presenters have actually articulated every little thing to details, and with a lot of people having interest and still stayed after 2 hours of presentation. So we are very grateful, and we look forward to fighting these pandemics or epidemia or any other health hazards. We'll fight them together. A lot of resolutions have been passed quite recently, just last week in Geneva. We had the opportunity to participate, and one of the most important things has been the pandemic fund, where we look at how best all countries, irrespective of their state of finance, can be supported to always deal with these issues. And in our case, once we start dealing with this, we need to look at our neighborhood as well. Because the neighboring countries. Sometimes if we don't engage them, we might be eliminating a lot of these diseases, and then you get one person travel in, and that is another challenge. So we are in contact with our neighbors as well to take a keen look into any disease outbreak so that together we can have it done very well. So once again, thank you everybody for spending all your time a Sunday like this and being part of this important engagement. Thank you. And Dr. Lai for putting all this together. Just want to say thank you so very much. Keep it up, and then we'll have a better health service system. Thank you.
Thank you very much, DG, once again, and also for making the time to join us. We were very privileged to have you on the call. So I'll address, I think, one issue which had to do with the availability of kits and also issues around training. So because our functional unit for the health system is the district health directorates, I'm going to kindly ask that for all of us who have concerns about the availability of kits to contact our district health directorates. We will work with the regions to make sure that those are available, and then the regions would also ensure that they are down to the district. So please do get in touch with your districts. And if you do have any issues, we'll put our contacts in there. You can also get back to us if you don't have any satisfactory results from them. The second issue about training beyond this forum and going to the lower levels, we as a service are using multiple strategies. So this is just one of them. Last week, the same team did a training of trainers workshop in Koforidua for our teaching and regional hospitals and some selected quasi-government hospitals. And the plan is to do cascaded training further down. And then we also are looking at getting training done for the private health facilities as well. So we have a number of activities planned, and we're hoping that we can reach all the areas of concern in this outbreak. And as DG said, we have to all work together on this to make sure that we see to the end of this outbreak. So that will be the response. I think there was another one on maybe the regions affected. So we currently have 9 regions affected. The official communication, as Mrs. Enim indicated, will be put out there. But for the purposes of this meeting, we can confirm that 9 of our regions have confirmed cases now. Bono, Central, Eastern, Greater Accra, Northeast, Northern, Volta, Western, and Western North. And so these are the ones that we have confirmed cases. The specific details of the numbers will be in our situation report and the updates which will be put on our social media pages in due course. So in the order of presentation, I'm going to ask our presenters to address any other burning issues. Unfortunately, for the sake of time, we may have to defer questions for now. But if you do have any pressing ones, we'll leave the Q&A still open, even at the end of the session. So you can type the questions there and we'll respond so that we can formally close. So I ask in the order of presentation. So Dr. Arthur, and then Dr. Boateng, and then Dr. Kome, and then Mrs. Enim, in that order. And then Dr. Taub, you can close us. So thank you, and over.
Okay, thank you very much, Dr. Lai. I think that during the presentations, we have addressed majority of the questions in the Q&A. I think one thing I'll take advantage to cover is, let me put it this way, the 221s. The 21 keeps appearing, and so it can be confusing. We mentioned a maximum incubation period of 21 days. An incubation period means that the person has likely not yet exhibited any symptom. So that is a period of waiting to see whether the exposure to the virus would lead to disease. And it's the same 21 day we are trying to follow contacts for. So let's understand that one. And then, as Dr. Comey alluded to, when symptoms start, all the way to when lesions, the rash, the crusts, all those things go away, it also tends to take another 21 days. So up to 3 weeks after symptom onset, at that point, everything is gone. And that confirmed case, it's also considered non-infectious anymore. So let's appreciate the 221s so that it does not look like the recommendations are overlapping. Thank you very much.
Thank you. I think a lot of my questions, a lot have been answered, but most people are still asking about the logistics to use. There is a distribution of the VTM and swabs to our regional medical lab scientists. And so if you need any and you are within the regions, kindly contact them for sample containers. If you don't have enough, they will reach out to me and then we would work out at that. I must say that if you have any other issues, since we are way behind time, as Dr. Lai said, our contacts will be shared. Kindly see or kindly call me, and then a lot of your questions will be answered. And if it has to do with logistics, again, when you contact us, that will also be sorted out. On that note, I want to thank everybody. Thank you.
Thank you very much. I don't have much to say, but to insist or to stress the fact that it looks as if a lot of people kept on asking, could we use alcohol hand wrap in places where hand washing facilities is not available? I must categorically state that the provision of hand washing facilities is non-negotiable. Veronica buckets have been used in the past. We use them in COVID, and they should be made available. Even with the use of alcohol hand wraps, it's expected or recommended that after using for about 5 times, you need to wash your hands with soap and water. So you cannot replace hand washing with alcohol hand wrap. Hand washing is key, must be provided, is not negotiable, and it will be supported by alcohol hand wrap. That is all I want to say when it comes to IPC and case management. Thank you very much for staying on the call.
Okay, thank you for the opportunity once again. So a few issues that I picked up in the Q&A had to do with how we can access the jingles and the materials that I spoke about. So we'll share them as part of this package with the slides so that we can all have access to them and use them. And again, there was an issue about if we had picked up any misinformation through our social listening on the outbreak response, anything that could affect the response. Let me just say that so far we haven't picked up anything that threatens the response efforts. And this, I must say, we want to thank our very esteemed team that is on here, the panelists on this call. They have been in the forefront of the national engagement on television and radio, giving information and educating the public, as well as some other senior people within the service. And therefore, with our lessons that we learned from COVID, what I'm seeing is that because now we are ahead, so the media is rather, we have given the information out and they are now asking us follow-up things. They didn't find out and now we have to go chase them. So the information that we gave out early has helped. We just have to be consistent with it. So across all levels, we all have to keep at it and ensure that the message is giving out there. Having said that, the social listening continues. So there's an insights team at the Health Promotion Division, as well as the PR unit, that picks up these issues on the various social media platforms, as well as newspapers, TV, and even on ground in the communities on the conversations that are happening so that we are able to respond to them in good time. So that work is going on beautifully, and that is, I think, why we haven't gotten any negative reportage around the response so far. So that is what I would say for now. Thank you, and over.
Great. Thank you very much to all our panelists and to you, the participants. We still have some questions coming in. But the one I want to address, I know we indicated that we have sought for continuous professional development points with the Allied Health and also with the Medical and Dental Council. We are fashioning out the ones for the nurses, and we'll clarify that soon. But we have the list of all participants on the call, and so we are going to ensure that the CPD points that are due you would be allocated to you in due course. The question about the availability of the presentation, so we've answered that as well. This session has been recorded. The video is on the YouTube page. The link has been shared. And so please kindly go there. You can be able to watch it or even download that. So those are the two comments I would want to add on. Dr. Tawab, please, over to you to wrap us up. Over.
Okay, thank you very much, Dr. I think you beautifully wrapped it up. So we want to thank everybody who joined this ongoing session, and we'll be back soon with another session. Thank you very much to everyone, and have a nice evening. Bye-bye.
Goodbye.